All right, welcome. We're about to dive into a super high yield topic for your anesthesia finals, and honestly, for everyday practice: oxygen transport. Nailing these concepts isn't just about passing an exam, it's about understanding the core of what we do. So let's get into it. So let's kick things off with a scenario that every single one of us in this field has to face. Your patient goes apneic, they stop breathing. Now, the difference between a nice, calm, controlled situation and a frantic, high-stakes crisis can be a matter of minutes. By the end of this, you'll know exactly what buys us that precious time. Okay, so here's the game plan. We'll start with the fundamentals, how blood actually carries oxygen. Then we'll meet the star of the show, hemoglobin. After that, we are going to master the famous oxyhemoglobin dissociation curve and its shifts. And finally, we'll tie it all together and bring it right back into the operating theater. First things first, let's get down to basics. How does oxygen actually get from the lungs to, say, your big toe? Well, it turns out it travels in two main ways. But as you're about to see, one of these ways does pretty much all of the heavy lifting. Now, just take a look at this. It's pretty stark, right? A whopping 98% of all the oxygen in your blood is physically latched onto hemoglobin. Only a tiny little 2% is just dissolved in the plasma. But, and this is the really cool part, don't you dare ignore that tiny little 2%. It plays an absolutely critical role. And here it is, the equation you absolutely need to have in your back pocket for exams, the oxygen content equation. This formula basically just adds the two forms together. You've got the part bound to hemoglobin, and you've got the part dissolved in the plasma, which is directly tied to the partial pressure of oxygen, the PO2. Let's make this real with some numbers. Okay, so let's plug in some typical numbers here. In arterial blood leaving the lungs, you can see hemoglobin is carrying 19.5 milliliters of oxygen, while only 0.3 milliliters is dissolved. It's a no-brainer. This just hammers home how incredibly efficient hemoglobin is at its job. So you're probably thinking, if it's only 2%, why are we even talking about it? Well, here's the thing, and this is the key takeaway, that dissolved oxygen is what creates the pressure. It creates the PO2. Think of it like this. The dissolved oxygen is the push that shoves O2 out of the blood and into the cells that need it. Hemoglobin then acts like a giant storage tank, releasing more oxygen to keep that pressure up. So how much oxygen are we actually using? On average, a resting adult is burning through about 250 milliliters of oxygen every single minute. That's our baseline, our metabolic engine just ticking over, the constant demand we have to meet. And this right here, this visualizes our problem perfectly. Our total oxygen bank account, what's in our lungs and our blood, is only about 1550 milliliters. But we're withdrawing 250 milliliters from that account every single minute. The math is simple, and it's not in our favor. This is why things can go south so quickly during apnea. So this naturally leads us to the absolute star of the show, hemoglobin. Let's take a closer look at this incredible molecule. It's not just a taxi for oxygen, it's more like a super smart, adaptable oxygen magnet. The genius of hemoglobin lies in this amazing property called cooperative binding. It's a bit of a process. The molecule starts out a little stubborn. It's in what we call a tense or T state, and that first oxygen has a tough time getting on board. But once it does, everything changes. The molecule literally changes shape, making it easier for the second one, which makes it even easier for the third. By the time we get to the fourth oxygen, it binds about 300 times more easily than the first. Incredible, right? And that beautiful cooperative process is exactly why the most famous graph in all of respiratory physiology has that iconic S shape. It's a direct reflection of that changing affinity. Okay, let's talk about the big one, the oxyhemoglobin dissociation curve. Seriously, if you can truly wrap your head around this graph, you've nailed the very heart of oxygen delivery. It's that important. So here it is in all its glory. On the vertical y-axis, we've got how full hemoglobin is. That's the saturation, or SaO2. And on the horizontal x-axis, we have the oxygen pressure, the PO2. The curve simply shows us the relationship between the two. Let's break this curve into two parts. First, look at the top part. See how it's pretty flat? This is a fantastic design feature. It means even if the oxygen pressure in your lungs drops quite a bit, say from 13 down to 10 kilopascals, your saturation stays really high, well above 90%. It's our built-in safety net in the lungs.
Now let's slide down to the steep part of the curve. This is where the real magic happens out in the tissues. Here, just a tiny drop in the local oxygen pressure, because a cell just used some up, causes hemoglobin to dump a ton of oxygen right where it's needed. It's an incredibly efficient delivery system.
But here's where it gets even cooler. The body isn't static. It's dynamic. It can actually shift this entire curve to the left or to the right to fine-tune oxygen delivery on the fly, depending on what the body needs.
Okay, left versus right. Here's a simple way to think about it. A shift to the left means hemoglobin loves oxygen and holds onto it tightly. A shift to the right means it releases oxygen more easily. We measure this with a value called the P50, which is just the pressure where hemoglobin is 50% saturated. A right shift means you need a higher pressure to get to 50% fall.
So what causes the curve to shift right to release more oxygen? Well, just think about a muscle that's working hard. What's it doing? It's churning out CO2, it's getting acidic, it's heating up. All these things are signals that tell hemoglobin, hey, we need that oxygen over here right now.
And for your exams, you've got to love a good mnemonic. To remember all the things that shift the curve to the right, just think of the word cadets. C for CO2, A for acid, D for 2,3-DPG, E for exercise, T for temperature, and S for sickle cell. It's a lifesaver. This whole elegant system actually has a name, and you've definitely heard it, the Bohr effect. It's just the fancy term for this incredible process where active tissues automatically get the extra oxygen they're screaming for. It's physiology at its absolute best.
All right, we've done the deep dive on the physiology. Now let's pull it all back into our world, the operating room. How does this actually change what we do every single day to keep our patients safe?
And now we can finally answer that question from the very beginning. Why do we pre-oxygenate? Look at this. Without it, your patient is breathing air. They have a little bit of oxygen in their lungs, and you've got maybe a minute before their sats start to drop. But if you take just 3 minutes to pre-oxygenate, you wash out all that useless nitrogen, and you fill up that lung reservoir with pure O2. You've just bought yourself up to 8 minutes of safe apnea time. That is physiology in action, saving lives.
And by the way, all the core concepts we've talked through today are beautifully laid out in the Respiratory Physiology chapter from the FRCA Primary Viva Topics series. It is a fantastic resource if you're in the middle of studying.
So here's the real takeaway. Mastering this curve isn't just an academic exercise to pass an exam. It is a clinical tool. The next time you have a patient who is septic, acidotic, or really cold, think about their curve. Where is it? How is it affecting their oxygen delivery? And how are you going to use that knowledge to stay one step ahead and stop a crisis before it even starts?